Management of beta thalassemia in pregnancy. Green Top Guideline number 66, March 2014. Purpose and scope. In this guideline, thalassemia major women are those who require more than 7 transfusion episodes per year, and thalassemia intermediate women are those needing 7 or fewer transfusion episodes per year, or those who are not transfused. Women who are thalassemia carriers do not require transfusion. Introduction and background epidemiology. Hemoglobinopathies are one of the most common inherited disorders. More than 70,000 babies are born with thalassemia worldwide each year, and there are 100 million individuals who are asymptomatic thalassemia carriers. The basic defect in the thalassemia syndromes is reduced globin chain synthesis, with the resultant red cells having inadequate hemoglobin content. The pathophysiology of thalassemia syndromes is characterized by extravascular hemolysis due to the release into the peripheral circulation of damaged red blood cells and erythroid precursors because of a high degree of ineffective erythropoiesis. Thalassemia major, or homozygous beta thalassemia, results from the inheritance of a defective beta globin gene from each parent. This results in a severe transfusion-dependent anemia. The heterozygous state, beta thalassemia trait, or thalassemia minor, causes mild to moderate microcytic anemia with no significant detrimental effect on overall health. Thalassemia intermedia is defined as a group of patients with beta thalassemia whose disease severity varies. At the severe end of the clinical spectrum of thalassemia intermedia, patients are usually diagnosed between ages of 2 and 6 years, and although they survive without regular blood transfusions, growth and development are impaired. At the other end of the spectrum, there are patients who are completely asymptomatic until adulthood when they present with mild anemia and splenomegaly, often found by chance during hematological examinations or family studies. The diagnosis is dependent on the patient maintaining a satisfactory hemoglobin level at the time of diagnosis without the need for regular blood transfusions. Splenectomy is no longer the mainstay of treatment for these conditions, but a considerable number of both thalassemia major and intermedia patients have undergone splenectomy. The cornerstones of modern treatment in beta thalassemia are blood transfusion and iron chelation therapy. Multiple transfusions cause iron overload, resulting in hepatic, cardiac, and endocrine dysfunction. The anterior pituitary is very sensitive to iron overload, and evidence of dysfunction is common. Puberty is often delayed and incomplete, resulting in low bone mass. Most of these women are subfertile due to hypogonadotrophic hypogonadism and therefore require ovulation induction therapy with gonadotropins to achieve a pregnancy. Cardiac failure is the primary cause of death in over 50% of cases. Improved transfusion techniques and effective chelation protocols have improved the quality of life and survival of individuals with thalassemia. The mortality from cardiac iron overload has reduced significantly since the development of magnetic resonance imaging or MRI methods for monitoring cardiac or cardiac T2 star and hepatic iron overload or liver T2 star and FerriScan liver iron assessment. These methods are now available in most large centers looking after patients with hemoglobinopathies. Preconception care. What are the additional risks to the woman and baby? Thalassemia is associated with an increased risk to both mother and baby. In particular, there are the issues surrounding cardiomyopathy in the mother due to iron overload and the increased risk of fetal growth restriction or FGR. In addition, with around 9 months of little or no chelation, women with thalassemia major may develop new endocrinopathies, in particular diabetes mellitus, hypothyroidism, and hypoparathyroidism due to the increasing iron burden. What is the optimum preconceptual care for women with thalassemia? At each visit with the thalassemia team, there should be a discussion and documentation of intentions regarding pregnancy. This should include screening for end organ damage and optimization of complications prior to embarking on any pregnancy. Each specialist hemoglobinopathy center should have a guideline for the management of pregnant women with thalassemia. Women should be advised to use a contraception despite the reduced fertility associated with thalassemia. There is no contraindication to the use of hormonal methods of contraception, such as the combined oral contraceptive pill, the progestogen-only pill, the Nexplanon implant, and the Mirena intrauterine system in women with thalassemia. Women with thalassemia are best cared for in a multidisciplinary team setting, including an obstetrician with expertise in managing high-risk pregnancies and a hematologist. This team should provide pre-pregnancy counseling so that the woman is fully informed about how thalassemia affects pregnancy and vice versa. The preconception evaluation involves a review of transfusion requirements, compliance with chelation therapy, and assessment of the body iron burden. The assessment should include optimization of management and screening for end organ damage. Are there any interventions which are beneficial at the preconceptual stage? Aggressive chelation in the preconception stage can reduce and optimize body iron burden and reduce end organ damage. Desferrioxamine is the only chelation agent with a body of evidence for use in the second and third trimester. The optimization of iron burden is therefore critical, as the ongoing iron accumulation from transfusion in the absence of chelation may expose the pregnant women to a higher risk of new complications related to iron overload, particularly diabetes and cardiomyopathy. Pancreas. Diabetes is common in women with thalassemia. Women with diabetes should be referred to a diabetologist. Good glycemic control is essential pre-pregnancy. Women with established diabetes mellitus should ideally have serum fructosamine concentrations of less than 300 nanomoles per liter for at least 3 months prior to conception. This is equivalent to an HbA1c of 43 millimoles per mole. HbA1c is not a reliable marker of glycemic control as this is diluted by transfused blood and results in underestimation, so serum fructosamine is preferred for monitoring. Thyroid. Thyroid function should be determined. The woman should be euthyroid pre-pregnancy. Hypothyroidism is frequently found in patients with thalassemia. Untreated hypothyroidism can result in maternal morbidity as well as perinatal morbidity and mortality. Patients should be assessed for thyroid function as part of the preconceptual planning, and if known to be hypothyroid, treatment initiated to ensure that they are clinically euthyroid. Heart. All women should be assessed by a cardiologist with expertise in thalassemia and/or iron overload prior to embarking on a pregnancy. An echocardiogram and an electrocardiogram or ECG should be performed as well as T2 star cardiac MRI. Aim for cardiac T2 star greater than 20 ms wherever possible, as this reflects minimal iron in the heart. A T2 star of less than 10 ms is associated with an increased risk of cardiac failure. A reduced ejection fraction is a relative contraindication to pregnancy, and the management should be the subject of multidisciplinary discussions involving a cardiologist with experience of cardiac pathology and pregnancy, a maternal medicine specialist, a hematologist, and an obstetric anesthetist. Liver. Women should be assessed for liver iron concentration using a Ferri scan or liver T2 star. Ideally, the liver iron should be less than 7 milligrams per grams dry weight or DW. A target liver iron of less than 7 milligrams per grams dry weight is recommended because iron chelation is discontinued during pregnancy and therefore transfusional iron burden and the risk of iron overload related complications increases. If liver iron exceeds the target range, a period of intensive preconception chelation is required to optimize liver iron burden. If liver iron exceeds 15 milligrams per gram or dry weight prior to conception, the risk of myocardial iron loading increases, so iron chelation with low-dose desferrioxamine should be commenced between 20 and 28 weeks under guidance from the hemoglobinopathy team. Cholelithiasis is common in women with thalassemia due to the underlying hemolytic anemia, and they may develop cholecystitis in pregnancy. Women who have any evidence of cirrhosis, either due to previous hepatitis or as a consequence of severe hepatic iron loading, should be reviewed by a hepatologist. Liver and gallbladder and spleen, if present, ultrasound should be used to detect cholelithiasis and evidence of liver cirrhosis due to iron overload or transfusion-related viral hepatitis. Bone density scan. All women should be offered a bone density scan to document pre-existing osteoporosis. Serum vitamin D concentrations should be optimized with supplements if necessary. Osteoporosis is a common finding in adults with thalassemia. Most women with thalassemia syndromes are vitamin D deficient and often osteoporotic as well. All women should have vitamin D levels optimized before pregnancy and thereafter maintained in the normal range. Red cell antibodies. Alloimmunity occurs in 16.5% of individuals with thalassemia. Red cell antibodies may indicate a risk of hemolytic disease of the fetus and newborn. If antibodies are present, there may be challenges in obtaining suitable blood for transfusion. ABO and full blood group genotype and antibody titers should be measured. What medications should be reviewed preconceptually? Iron chelators should be reviewed, and deferasirox and deferapron ideally discontinued 3 months before conception. Desferrioxamine has a short half-life and is safe for infusion during ovulation induction therapy. Desferrioxamine should be avoided in the first trimester owing to lack of safety data. It has been used safely after 20 weeks of gestation at low doses. All biphosphonates are contraindicated in pregnancy and should ideally be discontinued 3 months prior to conception in accordance with the product safety information sheet. What is the importance of genetic screening and what procedure or procedures are involved for women with thalassemia? If the partner is a carrier of a hemoglobinopathy that may adversely interact with the woman's genotype, then genetic counseling should be offered. In vitro fertilization, intracytoplasmic sperm injection, or IVF-ICSI, with a pre-implantation genetic diagnosis or PGD, should be considered in the presence of hemoglobinopathies in both partners so that a homozygous or compound heterozygous pregnancy can be avoided. Egg and sperm donors considering IVF should be screened for hemoglobinopathies. Preconception counseling for women with thalassemia includes partner screening and genetic counseling, as well as the methods and risk of prenatal diagnosis and termination of pregnancy. In high-risk couples, PGD is an option. If the partner is unavailable, an offer of prenatal testing is appropriate. Due to the risk of hemoglobinopathy, potential egg and sperm donors are screened for hemoglobinopathies. What is the importance of immunization and antibiotic prophylaxis in women who are at risk of transfusion-related viral infections or have had a previous splenectomy? Hepatitis B vaccination is recommended in hepatitis B surface antigen negative women who are transfused or may be transfused. Hepatitis C status should be determined. All women who have undergone a splenectomy should take penicillin prophylaxis or equivalent. Women who have undergone splenectomy are at risk of infection from encapsulated bacteria such as Neisseria meningitidis, Streptococcus pneumonia, and Haemophilus influenza type B. UK guidance is that daily penicillin prophylaxis is given to all high-risk splenectomized patients. Women who are allergic to penicillin should be recommended erythromycin. All women who have undergone a splenectomy should be vaccinated for pneumococcus and Haemophilus influenza type B if this has not been done before. The pneumococcal vaccines such as Pneumovax 2 by Sanofi Pasteur MSD Limited, Maidenhead, UK, should be given every 5 years. What vitamin supplements should be recommended? Folic acid of 5 mg is recommended preconceptually to all women to prevent neural tube defects. Women with thalassemia have a much higher demand for folic acid, so high-dose supplementation is needed. Folic acid 5 mg daily should be commenced 3 months prior to conception. Antenatal care. How is specialist input delivered for women with thalassemia? The multidisciplinary team should include an obstetrician, a midwife with experience of high-risk antenatal care, and a hematologist with an interest in thalassemia. A diabetologist and cardiologist may also provide additional specialist input. Women with thalassemia should be reviewed monthly until 28 weeks of gestation and fortnightly thereafter. The multidisciplinary team should provide routine as well as specialist antenatal care. Women with both thalassemia and diabetes should have monthly assessment of serum fructosamine concentrations and review in the specialist diabetic pregnancy clinic. All women with thalassemia major should undergo specialist cardiac assessment at 28 weeks of gestation and thereafter as appropriate. Thyroid function should be monitored during pregnancy in hypothyroid patients. What is the recommended schedule of ultrasound scanning during pregnancy? Women with both thalassemia and diabetes have a higher risk of early pregnancy loss. Fertility treatment with ovulation induction, is often required to achieve pregnancy, so an early scan is indicated to determine viability as well as the presence of a multiple pregnancy. Women should be offered an early scan at 7 to 9 weeks of gestation. In addition to the routine first trimester scan, 11 to 14 weeks of gestation, and a detailed anomaly scan at 18 to 20 plus 6 weeks of gestation, women should be offered serial fetal biometric scans every 4 weeks from 24 weeks of gestation. How should the transfusion regimen be managed during pregnancy in women with thalassemia major? All women with thalassemia major should be receiving blood transfusions on a regular basis, aiming for a pre-transfusion hemoglobin of 100 grams per liter. How should the transfusion regimen be managed during pregnancy in women with thalassemia intermedia? If there is worsening maternal anemia or evidence of fetal growth restriction, regular transfusions should be considered. If a woman with thalassemia intermedia starts transfusion, hemoglobin targets are managed as for thalassemia major. Women with thalassemia intermedia who are asymptomatic with normal fetal growth and low hemoglobin should have a formal plan outlined in the notes with regard to blood transfusion in late pregnancy. The decision to initiate a transfusion regimen is a clinical one based on the woman's symptoms and fetal growth. If there is worsening maternal anemia or evidence of fetal growth restriction, regular transfusions should be started, aiming for maintenance of pre-transfusion hemoglobin concentration above 100 grams per liter. Initially, a 2 to 3 unit transfusions should be administered, with additional top-up transfusion if necessary the following week until the hemoglobin reaches 120 grams per liter. The hemoglobin should be monitored after 2 to 3 weeks and a 2-unit transfusion administered if the hemoglobin has fallen below 100 grams per liter. Each woman's hemoglobin falls at different rates after transfusion, so close surveillance of pre-transfusion hemoglobin concentrations is required. Generally, in non-transfused patients, if the hemoglobin is above 80 grams per liter at 36 weeks of gestation, transfusion can be avoided prior to delivery. Postnatal transfusion can be provided as necessary. If the hemoglobin is less than 80 grams per liter, then aim for a top-up transfusion of 2 units at 37 to 38 weeks of gestation. What antenatal thromboprophylaxis is recommended? Women with thalassemia major or intermedia have a prothrombotic tendency due to presence of abnormal red cell fragments, especially if they have undergone splenectomy. These red cell fragments, combined with a high platelet count, significantly increase the risk of venous thromboembolism. This risk is highest in splenectomized women with thalassemia intermedia who are not receiving transfusions, since a good transfusion regimen suppresses endogenous erythropoiesis. Women with thalassemia who have undergone splenectomy or have a platelet count greater than 600 multiplied by 10 to the 9th power per liter should commence or continue taking low-dose aspirin of 75 milligrams per day. Women with thalassemia who have undergone splenectomy and have a platelet count above 600 multiplied by 10 to the 9th power per liter should be offered low molecular weight heparin thromboprophylaxis as well as low-dose aspirin of 75 milligrams per day. Women with thalassemia who are not already using prophylactic low molecular weight heparin should be advised to use it during antenatal hospital admissions. What is the optimum antenatal management of iron chelation therapy? Iron chelation therapy is complex and should be tailored to the needs of the individual women. The chelation should be managed by a hematologist with experience in iron chelation therapy, particularly during pregnancy. Management of women with myocardial iron. Cardiac MRI is safe in pregnancy and should be undertaken in women who have not received a preconceptual assessment or where there is concern about cardiac function. Women with myocardial iron loading should undergo regular cardiology review with careful monitoring of ejection fraction during the pregnancy, as signs of cardiac decompensation are the primary indications for intervention with chelation therapy. Those women at highest risk of cardiac decompensation should commence low-dose subcutaneous desferrioxamine of 20 milligrams per kilograms per day on a minimum of 4 to 5 days a week under joint hematology and cardiology guidance from 20 to 24 weeks of gestation. Women with myocardial iron loading and T2 star of greater than 20 ms do not require desferrioxamine chelation during pregnancy unless there is severe hepatic iron overload. Women with thalassemia major and myocardial iron loading with T2 star of less than 10 ms are at high risk of cardiac decompensation, which may present as increasing breathlessness, paroxysmal nocturnal dyspnea, orthopnea, syncope, palpitations, or peripheral edema. Presentation in the first trimester is associated with adverse clinical outcome. If a woman describes symptoms of palpitations, then a cardiac assessment is appropriate. A falling ejection fraction or increasing ventricular volumes on echocardiography will suggest increasing risk of developing heart failure. If the woman complains of palpitations, then a detailed history, ECG, and 24-hour ECG monitor assessment are needed to confirm a pathological cause. In either circumstance, desferrioxamine infusions may be indicated if there are concerns. Management of women with liver iron. High concentrations of liver iron greater than 15 milligrams per grams dry weight as measured by MRI are associated with an increased risk of myocardial iron, and in all women with thalassemia major, the therapeutic aim is to achieve a liver iron concentration below 15 milligrams per grams dry weight to reduce the risk of myocardial iron overload. Women with severe hepatic iron loading should be carefully reviewed and consideration given to low-dose desferrioxamine iron chelation from 20 weeks. Intrapartum care. What is the best intrapartum management for women with thalassemia major or intermedia? Timing of delivery should be in line with national guidance. Senior midwifery, obstetric, anesthetic, and hematology staff should be informed as soon as the woman is admitted to the delivery suite. In the presence of red cell antibodies, blood should be cross-matched for delivery since this may delay the availability of blood. Otherwise, a group and save will suffice. In women with thalassemia major, intravenous desferrioxamine 2 grams over 24 hours should be administered for the duration of labor. Continuous intrapartum electronic fetal monitoring should be instituted. Thalassemia in itself is not an indication for cesarean section. Active management of the third stage of labor is recommended to minimize blood loss. Postpartum care. What should be the optimum care post-delivery? Women with thalassemia should be considered at high risk for venous thromboembolism. Breastfeeding is safe and should be encouraged. There is a high risk of venous thromboembolism due to the presence of abnormal red cells in the circulation. Women should receive low molecular weight heparin prophylaxis while in hospital. In addition, low molecular weight heparin should be administered for 7 days post-discharge following vaginal delivery or for 6 weeks following cesarean section. Women with thalassemia major who plan to breastfeed should restart desferrioxamine as soon as the initial 24-hour infusion of intravenous desferrioxamine finishes after delivery. Desferrioxamine is secreted in breast milk but is not orally absorbed and therefore not harmful to the newborn. There is minimal safety data on other iron chelators. If a woman decides not to breastfeed, intravenous or subcutaneous desferrioxamine infusions are continued until discharge from hospital or until resumption of her previous iron chelation regimen under hematology supervision, whichever is sooner.